Good morning to everyone. I would like to thank the organizing committee for giving us the opportunity to present our center experience in management of mechanical circulatory, this one, VSR, and other mechanical complications of acute MI. There are three acute complications. One is VSR, second is ventricular free wall rupture, and third one is papillary muscle rupture, leading to cardiogenic shock, followed by the sequelae of cardiogenic shock, and eventually the death. The caution study data is a multi-center data which collects data of mechanical complications of acute myocardial infarction. Our center is a part of this data collection, and there have been few publications from this data, which I will just mention. One is surgical treatment of post-infarction ventricular septal rupture. I will describe this article in coming slides in the VSR. Another data is from the pre-wall rupture. It is again a caution study data, and it had 114 patients with a mortality of over 36%. The rupture rate was around 7.1%. The papillary muscle rupture, again a caution study data. We show 214 patients. This is the largest series in the literature so far, mortality of 25%. And there was no improvement over a period of 2 decades in the mortality, which ranged around 25%. Extracorporeal life support, it is another article from the caution study data, did not show any improvement with support of extracorporeal life support in these patients. Our center, we did 28 cases of mechanical complications post-MI. VSR is a commonest 19, pre-wall rupture in 2, papillary muscle 2, and pseudoaneurysm. Although it is a chronic, subacute, it was 5. We had a mortality of 21%. All of these 6 patients are from the VSR group. There was no mortality and other complications. I'll be focusing on VSR now. It's a devastating complication post-acute MI. Although the incidence has decreased recently, still the mortality is around 50%. It is the highest mortality among all cardiac surgical procedures. The STS data, around 3,000 patients over a decade period follow-up, did not show any improvement in mortality, which is 40 to 50%. This is surgical post-infarction ventricular septal rupture caution study data. It was from 2001 to 2019, 475 adult patients, largest study till date I know of, with a mortality of 40%. The most important controversial issue is the timing of surgery. As per the American Heart Association, they recommend emergency surgery should be done even in hemodynamically stable patients because they can show a sudden deterioration in clinical condition and have a hemodynamic collapse. However, the European Society, they recommend early surgery. Those who do not respond to the medical management, and delayed surgery can be performed in those patients who show a good medical management response. Now, our center experience in VSR in King Fahd Medical City. From 2017 to 2024, we did 18 patients. We did 18 patients. I did not include the last month. We had one more patient, which is not included in this study. Overall age was 50 to 60. We had a couple of patients who were 80 years of age. Mostly they were the males. Multivessel was 50% and the single vessel was 50%. Most of them were in cardiogenic shock, which needed IABP or inotropic support. Anterior septal was commonest 13, inferior was 5. Simple, which is a through and through hole, was seen in 12 patients, and complex was in 6. Associated procedure was done in 50% of the patients. One patient has an associated aneurysmectomy, and one patient underwent mitral valve replacement. We observed 28% mortality, 72% survived. Residual VSR was seen in 5 patients. They did not impact their mortality. However, one patient needed a percutaneous closure because of persistent heart failure. Those who are operated early within 7 days They had a 38% mortality, and those who were operated later on after 1 week, they had, none of them died, but they were only 5 patients. Associated CABG, those who underwent associated with CABG had an 11% mortality, those who did not have a 33% mortality. This is one of the patients who had a large anteroseptal MI, followed by the VSR. Another patient who had a large VSR, he had an aneurysm as well as the severe LV dysfunction. This intraoperative photograph, which shows anterior VSR. It is fixed with the infarct exclusion technique, double layer, and the patch is brought anteriorly to the anterolateral aspect of the LV to exclude the infarct, and this is then closing the ventriculotomy. This is a post-op echo, which shows a patch which is a little bit loose to avoid the adhesions. We confirmed that there was no shunt, which was confirmed by MRI. Another patient who had aneurysm, and he had a serpentine course of the VSD. He was taken by cardiologist to the operated cath lab. He could not pass the wire. I took him to the surgical room, fixed his VSR, and resected the aneurysm. Last month, we had this interesting patient who had a double mechanical complication. He had a VSR fixed with double patch technique, and then he also had a papillary muscle rupture, which needed a mitral valve replacement. This interesting case had a VSR with ASD. The interesting part is that, RV was chronically dilated, it was pressure loaded and volume loaded. It had an impact and it decreased the shunt across, and patient was very stable preoperatively. He did very well. This is home take message is that post-myocardial infarction ventricular septal rupture is rare but potentially fatal complication. Surgical correction carries highest mortality among all cardiac surgical procedures. Clinical presentation predicts the outcome. Treatment strategy should be individualized according to the patient's clinical status and hemodynamics. Successful surgical outcome depends on the prompt recognition. Thank you.